Thank you very much. And I'd just like to highlight that I'm presenting this talk on behalf of my very talented PhD fellow, Dr. Erica Flores, who unfortunately can't be with us as she has a new baby. Oh, hang on, I've done something. Oh, there we are, thanks. So I'd just like to begin by acknowledging the traditional custodians of the land upon which the research in Australia was conducted, the lands of the Kulin Nation, and pay my respects to elders past, present and emerging. These are my disclosures. So primary liver cancer is estimated to be the 7th most common incident cancer worldwide and has an abysmal 5-year survival globally of between 17 to 20%. Around 90% are hepatocellular carcinoma and around 80% occur in people with cirrhosis. In Australia, where I'm from, around 2,800 cases are diagnosed each year newly, and almost as many people pass away from this condition. And if you look at the blue incidence graph shown on the left and the red-orange mortality graph shown on the right, you can see that the Asia-Pacific region is disproportionately affected by HCC and that Australia has moderate incidence and mortality. There's been a significant shift in the epidemiology of HCC in Australia, as there has been internationally, and the blue graphs from 2012-13 highlight that hepatitis C at that time was the leading cause, followed by alcohol-related liver disease. However, the orange bars in 2021 to 2022 show that significant drop in hepatitis C-related HCC, thanks to universal access of DAAs in Australia from 2016. And increasingly, we're seeing MAFLD as the lead cause, and alcohol has remained relatively steady over time. However, we know, despite the excellent efforts we've made with hepatitis C in achieving cure for many people, for those with cirrhosis at the time of SVR12, there's still a residual 3 to 7% annual risk of HCC. Therefore, we need to keep these people linked to care and surveillance ongoing for HCC. If we consider the pathway of care for people with liver disease, screening and treatment of liver disease has really been the focus of the WHO and our national guidelines in Australia, and particularly the focus of viral hepatitis programs, including those that are decentralised. Whereas the steps of the screening for liver fibrosis, confirming diagnosis of cirrhosis and linkage to specialist care and cancer surveillance have perhaps been under-investigated in Australia. So the aims of our study were to describe the cascade of care in people with hepatitis C-related HCC, to describe factors associated with receiving hepatitis C treatment, being evaluated for cirrhosis and being enrolled in HCC surveillance, and thirdly, to describe the impact of achieving cure on HCC survival. So this was both a retrospective and prospective cohort study, including all consecutive incident HCC cases diagnosed within my state of Victoria. It was conducted between the 1st of January 2018 to the 31st of December 2021, with the prospective component from 2020 to 2021, and a further follow-up period to December 31 of 2022. It included all our tertiary health networks in the Greater Melbourne area that provide services for people with HCC, and we collected demographic, clinical and treatment data from electronic medical records and real-time attendance at HCC multidisciplinary team meetings. We performed descriptive statistics comparing HCV-related HCC to non-hepatitis C-related HCC, and we explored factors associated with survival using Cox proportional hazard modelling. So we had 1,013 incident HCC cases during the study period. 348 or 34% were due to hepatitis C. The key factors that were different among people with hepatitis C-related HCC compared to HCC due to other causes were that their median age was younger at 61 years compared to 70 years. They were predominantly Caucasian or Aboriginal and Torres Strait Islander descent. They had less prevalence of metabolic syndrome cofactors, but were more likely to have current alcohol misuse, be smokers, and have a strong history of past or current injecting drug use. They also had a higher proportion of burden with mental health conditions as well. Interestingly, I'll highlight here that 2/3 of the people diagnosed with hepatitis C-related HCC were not known to be someone who injected drugs in the past or currently, and did not identify as someone who injected drugs. If we now move to the cascade of hepatitis C care for those with HCC, among those who presented, 61% had been cured with treatment, meaning that almost over 1/3 had never been treated for their hepatitis C. If we look at cirrhosis, 95% had cirrhosis at the time of diagnosis, yet only 72% of them were aware of that diagnosis. Concurrently, only 50% were enrolled in HCC surveillance at the time of HCC diagnosis, and 45% had had a scan within the preceding 12 months. Despite that, there was no difference between hepatitis C-related HCC and other causes for diagnosis at early stage. So around 50% were diagnosed with early stage HCC, and around a third received curative therapies first line. Importantly, if we consider where these people had engaged with the health services, 8% of those who'd been treated for their hepatitis C had not been assessed for cirrhosis, and 26% who'd been treated had not been enrolled appropriately in HCC surveillance. If we then explored factors associated with receiving hepatitis C treatment, the only factor that stood out is you were half as likely to have your hepatitis C treated if you had current alcohol misuse. You were also half as likely to be evaluated for cirrhosis if you had current alcohol misuse, despite this being a risk factor for cirrhosis in its own right. And you were half as likely to be enrolled in surveillance if you had current alcohol misuse, and also if you were a male. Interestingly, when we looked at those who were linked to specialist care, you had a 12.25 higher odds of receiving HCC surveillance compared to if you were from another specialty or from primary care. We then looked at factors associated with survival in hepatitis C-related HCC, and looking at crude analysis, the achieving SVR with treatment was associated with survival, with around a 40% reduction in mortality. However, when you adjusted this for age, child PUE status, surveillance and BCLC stage, this association was then negative. And this really highlights the critical aspect that treatment is one component of how we improve mortality, but without linkage to care, and particularly HCC surveillance, we may not be able to improve mortality. So in conclusion, there are still major gaps in hepatitis C cascade of care for people with HCC in Australia. A third of people were presenting who didn't know and hadn't had their hepatitis C treated. A third of them were unaware they had cirrhosis, and half of them were not enrolled in HCC surveillance appropriately. Importantly, people with alcohol misuse were half as likely to receive every step of the hepatitis C cascade of care. We need interventions to achieve equity in this group in the cascade of care for hepatitis C. Finally, we would suggest that our research suggests we move beyond the virus. There's been a very strong focus on test and treat in Australia, but there's an urgent need for more holistic care targets, including for cirrhosis assessment and appropriate HCC surveillance enrolment. I'd just like to acknowledge again the work of Erica on this, and she did a wonderful work on this study, and also my collaborators across the Melbourne Liver Group and also Burnet Institute and our funding partners. Thank you.